Hello, everyone, and welcome to week 2. It's good to have you back this week, or if you're working ahead, it's good to see you again. So this week we are covering clients at risk, and we're going to talk about suicidal and homicidal ideation, including assessment, prevention, intervention, and ethical obligations. And some of this will be content that we will follow up on in later weeks as well. So here's our agenda. Again, we'll be talking about homicide and intimate partner violence. We'll be talking about suicide, different models of assessment and treatment. I do want to make a note that this is rather heavy content, and so please do take care of yourself throughout this. You can pause and come back to the video. You can stop the video and finish it another day. Do whatever you need to do to help you get through this. So first, we're going to talk about homicide. And I decided to start here because we didn't cover this much in 550. And so it is important to come back to this and talk about it more. First, I have some data for you on homicide rates. And I will say, you may be wondering, where did you get your data from, Dr. Sherman? Well, data around homicide in particular is not the easiest to nail down. And so I looked at multiple sources over the last about 10 years and took some averages. I tried mostly to use government websites, though I did use some focus group websites as well. But I did try to stay away from any that may have reasons to skew the data. And so I stayed away from any sort of like sources that could be questioned. So in general, these are, examples, but also estimates of the statistics. And so would I say this is the exact statistic of these things? No, but I would say it's a good ballpark. Around 5% is the homicide rate in the US over the last 10 years or so, and over half of that is contributed to firearms, and the higher end of that percentage that I found was about 3.5%, which is more than 50% of 5%. And I think it's important to think about who is it most at risk for homicide. Unfortunately, age is a factor, and in the 10 to 24-year-old group, homicide is the second to third leading cause of death, which is a pretty significant number. And I think we've seen those numbers rise in, probably the last 20 years due to events like school shootings. In addition, race, particularly if you're a member of an underrepresented group, makes you more at risk for homicide, particularly Native Americans, African Americans, and Hispanic folks tend to have a higher risk for homicide. Gender, it actually, you are at a higher risk if you are a man or a male, as far as being at risk for homicide. The statistics are pretty strongly in the favor of men versus women in that category. And then finally, you are more at risk of homicide if you have a military affiliation. And I did drop some resources for these statistics in the Canvas shell under the resources page for this week if you want to learn more about some of those topics. So, as we start talking about this, I think it's important to just remember we're always thinking about demographics. We're always thinking about, how folks might be affected by the systems in which they interact with, including systemic oppression, and make sure that we center their experiences and really consider the culture and background of folks when we are doing any kind of working counseling, including homicide and suicide assessment. So how do we assess for homicidal intent? You have a client come in, or maybe you're on a crisis intervention team like we talked about last week, and it seems like they're having some ideation, but you aren't really sure how to assess for it. Well, the good news is most of your suicide assessments, including the SLAP that you learned in 550, can be applied to homicide assessment as well. So you don't necessarily have to have a brand new assessment that you have memorized or, sort of on call for homicide assessment. But there are some different things to think about when you consider homicidal intent. The first is risk factors for violent behavior. The more of these that a person has, the more likelihood that there is a risk for violence, including homicidal intent. And I put a resource in your Canvas page for this week, which is the violence risk assessment. And there are some specific questions throughout that that talk about factors like revenge and weapons, violence. So some of the violence related questions are related to video games. Some are related to violence in the home or violence that the person has witnessed. Some of them can be used with adults or teenagers. So you can use this assessment and kind of edit it based on what population you are dealing with. One of the questions is tell me about your experience with violence and things like that. What was the last physical fight you were in? So there are some good resources for trying to assess, how many risk factors somebody might have for violent behavior so that you are able to get an idea of their risk factors for violence. So I already mentioned you can use most suicide assessments for homicide assessment as well. There are some others that I have put in your Canvas page that are specifically for suicide and or homicide and has questions written as both. And so that's a good document to look at as well. So I do want to follow up on duty to warn. And once again, this was a topic that I covered in week 7 of 550. But I think it's important that you always know what your duty to warn is. What are your state laws? What are your ethical requirements? Again, I posted the picture of the Oregon statute and their stance on duty to warn. But there are also links in the page this week for you to look up your state if you're in a different state or learn more about duty to warn and when that comes in, when you should break confidentiality in order to warn a person about potential danger. And then finally, as I mentioned earlier, I do have an assessment example specifically in Canvas that is for suicide and or homicide, and it's under your resources, and it's called the Suicide/Homicide Risk Assessment. And it is a thorough assessment that you can use to walk through specific with questions for homicide. That can be helpful. And I have used that in my practice as sort of my go-to instrument if I'm worried about assessing for homicidal intent. The SLAP tends to be my go-to for a suicidal assessment that I can remember off the top of my head. We're going to talk about more in-depth suicide assessments in a bit. But this particular one that I have put in Canvas for you called the Suicide/Homicide assessment is the one that I like to use for this specific concern. All right, so we're going to move into intimate partner violence or IPV. And you may have heard this referred to as domestic violence. That tends to be a term that's used more in law enforcement these days versus mental health. They do often refer to similar or the same thing, except domestic violence is a crime, and that's typically how the verbiage is used in criminal proceedings. I also do want to give you a note just that we're going to cover IPV a little bit more later in the term. And so this is an overview for us to start thinking about it and start thinking about how we would approach folks with IPV. And as someone who worked in child abuse pretty significantly through most of my clinical work, I can tell you that a lot of times these two things go hand in hand. I did often treat the non-offending caregiver, which many times was also a survivor of IPV. And so even if this maybe isn't an area that you think that you're going to work in, it's still very important for you to have knowledge on it, to have resources for it, and be able to address it with clients. And you also never know, even if you're just in general practice and you are, kind of serving your community in different capacities, you never know who will come in that may be in a situation that you never would have guessed from the outside involves IPV of some sort, because there are unfortunately many kinds of that. So again, this is an overview. We're going to talk about this more a little bit later in the term, but it is a very significant issue. Over 12 million people per year are impacted by this, and that is across the board. That is not a specific gender. We know that, and this is talked about a little bit more in the Carlson Continuum of Conflict article that's in your resources, but IPV can go both ways in a relationship, and so that is important to think about and remember when you are treating someone who's maybe in an abusive relationship. Unfortunately, female partners are more likely to be murdered during IPV incidents. And if there is a gun in the household, the risk of a woman being killed is about 500% more than if a gun was not in the household. It's just a little bit about gun legislation. In states that require a background check, about 38% fewer women are shot to death in IPV situations. And so one of the specific assessments that I want to suggest for this is called the danger assessment. That's also in your Canvas page for this week, but it's under your required reading. You do not have to memorize this instrument. In fact, if you just click on it, it'll give you an overview, and that's really what I want you to read for this particular week. The danger assessment is something that you need training in to use. So if you went on to do your practicum or internship in a domestic violence shelter or a women's shelter or some other agency that works with people who have survived intimate partner violence, this is an assessment that you might want to get trained in and invest in for future use. So that is a really good one that's specifically developed for IPV, and I think looks at both long-term incidents and the different ways that someone can be abused in a relationship. Another tool that you have probably heard of is the power and control wheel, and this can be very helpful for treatment of survivors when they are in counseling to understand what happened to them. Many times our culture tells us that we are not, we're not to be victims. Like you have to be stronger, and a strong person doesn't allow these things to happen to them. And those are all just blatantly untrue. Most people at some point in their lives can find themselves in a place where they are more susceptible to being in a relationship that is harmful in one way or another. And so a tool like the power and control wheel is a great way to use psychoeducation to help folks understand what abuse can look like kind of across the spectrum. And I found a really nice gender neutral power and control wheel that I did put in your reading for this week. Again, just take a look at that, maybe save it for later in case you would like to come back to it or use it with clients. And then in your resources, I found a page that has some little snippets of videos that kind of talk about the specific sections of the power and control wheel. This is something that we'll be coming back to when we are talking more about IPV later in the term. And then finally, in your extra resources, I did put an article that I like called The Continuum of Conflict by Dr. Carlson, which I have found to be a helpful resource when learning about this topic. All right, so now we're going to move into suicide, assessment, intervention, and also ethical obligations. We already talked a little bit about duty to warn for homicidal intent, but we'll also talk about it for suicide as well. So I first wanted to cover some of the risk factors, and I think that this was covered, maybe some in 550, but not to the extent that I'd like for it to be covered. And I'm going to talk through some of these, but I did put the NAMI, which is the the abbreviation of what it stands for just flew out of my head. I'll look that up later. Anyway, I did put the NAMI link in here, and so when you visit the Canvas page and you go to the bottom, you can see that there is a link for the lecture slides for today without my narration, and you should be able to click on the link from there. So NAMI is a good resource to learn more about suicide and to learn more about these specific items that we're talking about today. It's also a good resource for lay people if they need to understand more about it, and so that's something to keep in mind. So, suicide risk factors kind of run the gamut of, maybe sometimes these will fit and maybe sometimes they won't fit. But some of the things that stand out are demographics. So we know that once again, marginalized communities tend to have a higher risk of suicide attempts. We know that trans folks tend to have a higher risk, and so age is also another, looking at this list to see if I included that under the demographics or not, but age is another risk factor, and there are certain pockets of age where suicide risk goes up in older adults. And then like around the 40s, it goes up. And so while we tend to think of, suicide as maybe like typically maybe 20s or teens, there's actually times across our lifespan that the risk peaks a little bit more than typical. Unfortunately, single folks are more likely to be prone to suicide attempts, unemployed, folks that are struggling to meet, sort of their daily needs are more likely. Chronic illness, chronic pain puts you at greater risk. A lack of social support and family and friends that are willing to at least lift you up, kind of in times of struggle, even if they can't help you with maybe finances or other aspects that you're struggling with, can be a risk factor. Things like substance abuse, especially disruptive substance abuse on an extreme level, and then mental disorders can kind of, and it's one of those things where the more problems you have, it fills up, right? So kind of remember the balloon from our crisis intervention class last week. The more you blow into the balloon, the more likely it is to pop. And so all of these risk factors build on each other. And then if we move into the other side, command hallucinations, so that means hallucinations that are telling you to do something like hurt yourself or hurt others. And that could be anywhere from like cutting yourself all the way up to a very specific plan to kill yourself. In addition, trauma and abuse history, we know that, and we'll talk about ACEs and other, trauma and abuse history factors also later in the term, but we know that sort of the laundry list as it gets longer of your history of trauma and abuse, the more likely you are to have some suicidal ideation. A family history of suicide completion and or suicide ideation can put a client more at risk. As well as recent loss, so grief. The grief process is already pretty hard, and many times if people cannot find other reasons to stay alive, they can become suicidal. And then also the unwillingness to seek help. So, biased beliefs about that it may make you weak, or that, strong people don't need to seek help when they're struggling, but will put you more at risk. Cultural or religious beliefs that kind of feed into that bias against seeking help also put you more at risk, though, at the same time, they can be a protective factor, but we're not there yet. And then isolation, and that makes sense. Isolation and limited social support go together, because if you have limited social support, you likely are going to feel isolated. So those are some of the risk factors. I did put a website down here if you'd like to learn more about suicide statistics, but I'm going to move forward. So what are some of the protective factors? Effective care for both, your medical concerns, physical concerns like pain, also mental health concerns. Having that, it provides a level of support that even if you don't have social support outside, you are getting regular check-ins from someone who does care about you, even if it's on a professional level. Having access to care and interventions to help you, which I think goes hand in hand with having effective care, it will also lead to a protective factor. Being willing to seek help, so having that support, whether it's from your culture or your religion or your internal belief system and values, wherever it comes from, that belief that it's good to get help when you need it is a protective factor. Some other things like not having access to highly lethal means such as firearms is helpful. I think that makes sense, especially given some of the firearm statistics that we went over already. But again, this idea of connection to family, connection to community, connection to you as their counselor will all be helpful in protecting a client. And then conflict resolution skills. Now, this may depend on whether the client is in crisis or not and is able to access those skills, but if they've been able to troubleshoot through hard times in the past, then you can remind them that they have been able to do that in the past and they have it within them to do it again, even if it doesn't feel like it right now. And then finally, cultural beliefs that support self-preservation. So what are some of the warning signs and symptoms of suicidal ideation? I grouped these kind of by category. So first we have feelings of hopelessness, helplessness, anxiety, self-hatred, and sadness that doesn't go away. Now, again, you're not going to see all of these in every person that is suicidal, but typically there is a cluster that will become apparent to you of symptoms, most likely that will align with some of the symptoms out of this slide that will help you know when somebody is suicidal. Oftentimes it may be related to an event that leads to a person feeling lost, defeated, betrayed, or humiliated. I know in the 550 class that I taught, when students did their suicide assessment, many of them used situations where the person who was suicidal had been left by their spouse. And I think that that makes sense because that could be an incredibly stressful event that would lead to these feelings of betrayal and humiliation, as well as hopelessness and sadness. So some others are changes in behavior, such as recklessness, agitation, mood changes, their health hygiene, or I won't be needing this, or statements similar to that, which moves right into the idea of behaviors. Things like settling one's affairs, giving away possessions that they cherish. This might be a little bit harder to ascertain, but if they're rehearsing what they mean to do, if they've increased their substance use, or if they are saying goodbye. So again, you're not going to see all of these in every client who is suicidal, but you will likely see a cluster of these symptoms. So suicide assessment, according to the American Association of Suicidality, should include ongoing action. So if you're having sessions with this client that you see weekly, you want to keep doing the assessment every time you see them, just track things over time. You want to look for risk factors and protective factors. So bring in your strengths-based work here. You always want to look at level of risk and track that over time as well. Identify what their ideation is and any behaviors or plans for completing suicide. And then also those imminent risk and warning signs. So if I have a client come in that tells me that they gave away most of their possessions in the last week, to me, that's a pretty big red flag that this is very serious. And then finally, you want to consult. And I can't underscore the importance of consulting. If you are in session, you can always step out of session and tell the client, could you just stay here for a moment? I need to speak to someone else, or I need to, talk to my supervisor. Most of the time clients will stay. I don't think I've ever had anyone walk out when I said that I wanted to consult, especially prior to licensure. So that is a really important step to, I think, anytime you engage in a suicide assessment, to either consult before, during, or after that. Even if you determine the client to be not in great danger and you create a safety plan with them, you should still let your supervisor know so that you can talk about it the next time that you meet. So these are some assessment mnemonics, and you already learned SLAP, but sometimes people want options, and I have some other options here for you for mnemonics. So the first is path warm, the second is no hope, and the third is plaid, and last is the good old SLAP method. Whichever of these you can basically memorize and have on hand for yourself will work. These are intro level assessments to kind of get an idea about how the person is doing and then take next steps. As you can see on here, and I listed out the different aspects of each of these assessments, the no hope one tends to be a little bit more detailed. Is path warm is also fairly detailed. So those are, I would say, kind of fall in between basic to middle level of detailed assessments, whereas PLAD and SLAP are going to be kind of your basic assessments that you would use as a first step. And then if you found that the person does have a pretty serious intent, you might want to move into a more specific and advanced level assessment, which we are going to go over. The first thing we're going to go over is the simple steps model. And this is quite a hefty assessment for suicidal ideation, but it also gives you a lot of information. And it of course, the first question is the client suicidal? Are they thinking of killing themselves? And then from there, you move into sort of the earlier things you learned in the SLAP, things like their methods, specificity, etc. But then you get more information. So what type of pain are they in? Have they had losses? Do they have earlier attempts? And if you are remembering from just a few slides ago, what we're doing here is checking off those risk factors to see kind of where they are in that list. Are they using substances? Are they using them more than usual? You know, and so as we work through this list, you're getting history of the client and you're also getting risk factors and protective factors. And in the risk handout, and it's going to be in your Canvas page, I believe it is pretty far. Yeah, it's the second resource under their resources. It says risk assessment or RA handout, and it's one that I included that has all of the steps from Simple Steps in here with more information for you. So this is a good model to use. It's pretty all-inclusive of the things you need to know to make a decision about what level of threat the person is. Okay. Next, we're going to talk about the sad persons model. And for those of you that really like numbers and concrete guidance to help you make a decision, this is the model for you. So the sad persons model essentially has you assess the person through either asking them questions based on the acronyms to the far left of the model. Some of the things you're going to know. So you'll know about the gender, you will know about the age of the person, and so forth. So what you don't know, you will need to ask the person about. Hopefully you have already maybe done the SLAP at this point, so you know the specificity, you know the lethality, and so you can answer some of these other questions. But you might have to ask about previous attempts, drug use, social support, so that is covered in the SLAP, so you may be able to fill in that information. So whatever you don't have, you want to ask the client. And then there is a recommended score interpretation, and I apologize for cutting off the top of the heading here when I was creating the slide, but it does show you the scale, and it also shows you what you should consider as far as your recommendation for the client. So if they have a very low score, you just want to send them home with a follow-up. You might still consider doing a safety plan. Honestly, if you are assessing for suicidal ideation, you should do a safety plan. That's just sort of the bottom line, even if they have a lower score or limited ideation. If their score is 3 to 5, you're gonna closely follow up with the client. You may want to consider hospitalization. And as you move up 6 to 7, strongly consider hospitalization. You know, possibly make follow-up arrangements, and then 8 to 14 inpatient treatment is recommended, which would mean hospitalization plus a longer treatment term, that they would be in inpatient work to work on stabilizing them. That's most likely going to include medication. So again, if you like numbers and you like a guide, this is a good model to use that will help you kind of decide when you need to move from safety planning into hospitalization. And there's also an instrument or a version of this instrument that's adapted for children. So if that's something that you're interested in, or if that's a population that you want to work in, that is something that you could probably find through our library. And if it's not in our library, you could also request it through interlibrary loan. All right. I don't know why this picture didn't. Go back. Why it did not come in fully. That's really interesting, because when I was looking at it before, it seemed to have the full picture there. So I'll see if I can go back and adjust that. But this chart is to just help you think about the level of risk and ways that clients are more or less likely to have a lethal suicidal ideation. So things that result in higher levels of seriousness, if you will, when you're talking about risk, are things like, guns, hanging and jumping, jumping off a building, jumping off a cliff. There's going to be a high risk of them completing suicide with things like this. Moderate risk, drugs, alcohol, car wrecks, and then lower risk tends to be pills or / a person's risks. Now that certainly doesn't mean that a person could not complete suicide with these methods. But if we're going to talk about like just this column is lower risk, their plan is going to be vague, or they don't have a plan. They're available, the availability for the means they don't have available. So if they want to take pills, but they don't actually have any pills, it would show up here. They don't really have timing, or it's like past 2 days, that's considered low risk. They have others who can be their social support. They're not using alcohol or drugs. They want to live, and the problems may or may not be chronic, so acute versus chronic. So for folks who have chronic suicidal ideation, it does tend to kind of peak at times and then go back down, but it's something that gets revisited more often than with a client who has a very specific event that then causes them to be suicidal. And, that's something that I think it's good to explore in your diagnosis class or future classes in substance use. Folks who have chronic suicidal ideation is a very specific population, and I do think that you need more advanced training in working with them. I have worked with a couple of clients who were chronically suicidal as a result of their child abuse history, and it's a really, really tough population. And it's more about just that week to week, helping them want to stay alive, finding more reasons to stay alive than to not. But I'm sure it's a very, very hard way to live. And it's also pretty hard on the counselor to treat that population. So if you find yourself treating folks who are chronically suicidal, I definitely want to encourage you to limit your caseload of that so that you don't burn yourself out. Okay, moving on from my side note. For moderate risk, so these things are drugs, alcohol, car wrecks. There are some specifics. They probably do have the means, or they're close by. They have a shorter timeline. They may have other people close by, or they're expecting people to be close by, and so they're not completely isolated. They do have some level of drug or alcohol usage, but it's limited. They have some awareness of the desire to live, but they also have current ideation, gestures, and behaviors like recklessness that we talked about earlier, that indicates a more moderate risk level. And then lastly, the high risk, again, so these are things that are very lethal. If someone attempts suicide through one of these means they're more likely to complete the suicide. They are typically very specific. They know where they want to do it, when they want to do it. They have a reason why. They do have the means close by. They are looking at doing it in a very short amount of time and often have very little to no social support or folks who could intervene. So they're isolated, they live alone, or they are presently alone in their space. They may also, now this is not every case, of course, that's high risk. You're kind of looking for the different pieces that you can pull out. Not every high risk suicidal client is going to meet every one of these criteria, but they may also be heavily using drugs or alcohol. They don't have any ambivalence about whether they do or do not want to live. And more often than not, these high-risk clients are from an event that was very hard for them to deal with or live with. It could be some of that humiliation that we talked about earlier. It could be loss or grief or some other kind of traumatic event. So some things to think about just with this chart. It is very important to, after you do your suicide assessment, ask yourself, do I think they're low, moderate, or high risk? And then base your choices on what you do next on that assessment of level. All right, so what do we do next, right? And I feel like this is probably where we're going to talk more about things that we didn't get into as much in your assessment course. One of your first decisions is based on your plan, based on my assessment, do I think they need hospitalization or a safety plan? And again, if you've done a thorough assessment, you should know, you should have a pretty good feeling about what level of severity they are and if they are at risk of killing themselves, before you see them the next week. So think about their risk factors, but also their protective factors, their support, and their level of risk that you determined, like from the chart that we just talked about. Think about their perspective. And I would also say, think about if this was a person who didn't know the client, so maybe your peer came in and did the evaluation, would they come to a different conclusion? Do you have any bias in making this decision? I think is an important question to ask yourself. Is there an option for lowering the risk and elevating their safety? And so these are things like the client's willingness to get rid of their means, to tell a loved one. Are they willing to, go stay somewhere that they would be safer for the time being? Are they willing to participate in sort of that safety plan creation with viable options to help keep them safe? And the last, what does your intuition tell you? What does your gut say? And if you are uncomfortable with a safety plan, if you on any level feel like this is not going to be enough, or you are worried about the client maybe telling you something just to kind of get you off their back or mislead you, then you're going to have to think about hospitalization. And so that's the next decision. And in thinking about hospitalization, we want to always default to voluntary. So when you first start with a client and you're talking to them about informed consent, and you tell them, if you pose a risk to yourself or others, I'll have to break confidentiality. This is where that comes in, but only if they need to be involuntarily hospitalized. So if they agree to be hospitalized, and it's voluntary, then you can talk to them about that. Okay, let's make a plan. Do you need me to go with you? Do you want me to call someone to go with you? When are you going to go to the hospital? Can I make a list of different places you can go? So if you have maybe an inpatient clinic versus, admission to the ER, what are the local options? And so most of the time, if you have a good relationship with a client, if they are sort of that moderate, just edging into the higher risk area, they are going to more likely be willing to voluntarily commit themselves for a period of time. So, it's kind of very similar. You'd ask yourself the same questions that you do in decision one. But you also need to remember that, when you get through these and you're talking to the client about, I think you need to be hospitalized, I think it would be in your best interest until you can get through this, really rough patch right now. Make sure that you do talk to them about their risk factors, what you think their level of risk is. You want to create a strong rationale for them to be able to listen and be willing to voluntarily commit themselves. However, if they are not willing to engage in any of these practices, you will need to work on an involuntary hospitalization. And this is one of those things that none of us ever want to do. It's not a joy. It's not a great part of our job. It can break trust with a client. It's hard to repair relationship ruptures after you involuntarily commit a client to the hospital. So you would really only do this if you felt like you had no other option. And once again, different states will have different laws. I think it's very important for you to look that up. I didn't put that as part of your assignment, but now that I look back, I probably should have put that as an assignment to look up your involuntary hospitalization law for your state. In Florida, we have the Baker Act, which allows mental health or physical health professionals to involuntarily commit someone for 3 days. And for us to do that, the only way we have is to call the police, which can cause even more trauma. So that's not always the best way to build trust with the client, of course. Now, there are some newer options, and you'll find they may be county-based, or your state may have other options where you can call a crisis response team for the county, and they will send out somebody usually that works for the crisis center for that area. And that could be one county, it could be multiple counties. Again, if you're in a rural area, it might take them a good while to get to you. So that could be a consideration, but typically they are composed of a mental health worker that would probably do another assessment on top of yours. And it is likely that they would have law enforcement with them, though they may or may not be plainclothes, and they may or may not have a vehicle to transport the person in that is not a law enforcement vehicle. But that does really vary from state to state, and it also varies from county to county. The county that I lived in prior to where I live now was very well resourced. We had a great crisis center. We had multiple crisis response teams. The law enforcement were very well educated about working with folks in mental health crisis. And so they were far less likely to traumatize someone when they are taking them in for an involuntary hospitalization. But that is not the case in a lot of places. And particularly with communities who have higher levels of police violence, we really want to think about how we go about involuntary hospitalization and do it in the most respectful and kind way possible. So I feel like that's about all I want to say on that topic. I think I could go on for much longer, especially about the multicultural considerations. But first, I would just like for you to find some time to look into your state statute for that so that you know more about involuntary hospitalization and when you will be eligible as a professional for that. It's probably going to be after licensure. And then continue learning about it, continue learning about ways to be more respectful of clients that do have to be hospitalized against their will. And that includes children and teenagers too. It may be easier to get their parents on board, but they are still people and they deserve respect and kindness, and relaying that to them as much as you can is very important. So we've come to the treatment portion, and we're going to look at short-term and long-term treatment here. And there's some different means. So the first is to develop a safety plan. And I did put a safety plan guide in your Canvas page for you. It's the same one that I used in 550. But some of the questions to help guide you are also listed here. When should the client use the plan? What can they do to calm and care for themselves when they are feeling suicidal? What are their reasons for living? Who is their support? Who can they talk to? And if they don't have a family or friend, and you obviously are not on call 24/7 as a counselor, make sure they have the National Crisis Hotline, which is 988, and any local resources as well. And then safety is very important. Again, safety plan, right? So it's in the name. How can I make my environment safe? Are there people that I can give the pills to? Can I get rid of the knives? If I have firearms, is there a place that I could put them where they're secure for the time being? And what should I do if I'm still not feeling safe? That is a very, very important part of a safety plan, because if someone still isn't feeling safe, they need some place to go to. And so that might be a family or friend. It might be hospitalization, voluntary hospitalization, etc. And so that's a very important part of the plan that you want to make sure you write in. All of these things should be written down on something tangible, not a computer, a piece of paper, so that the person can access them anytime that they need to, whether they are at home or somewhere else. If you're providing outpatient care, so this is a client that you see and they've come in and they've been suicidal, and you've done the assessment and you've written a safety plan and you see them, the very next week you should assess for intent again. And in most follow-up sessions, now there may come a time 3 or 4 months down the road that you don't need to do this every session, or you're able to sort of, do it more succinctly than a full assessment. But in the immediate aftermath of it, you do want to follow it pretty closely, especially if it's grief or loss related. You want to provide your client with resources, and that will be also based on their reason behind the ideation. What do they need at this time? Are they struggling monetarily? Are they struggling with support? And how can you connect them with some resources? Both group and individual counseling is helpful, and so you may already be seeing them as individuals, but either you may run a group that could be helpful for them, or you may have colleagues or other resources in the area for group work. Groups are great for this, and I know you all haven't had your group class yet, but groups are so wonderful for the loneliness factor that tends to be a big part of suicidal intent. It creates community, it creates support, and it becomes another layer of protection. Another thing that you want to do is identify triggers for the ideation and also protective factors against those, and make sure that the client knows those so that they can look at their triggers, they can work on those and work on alleviating some of those, but also protective factors that they can go to in their times of need. And just a brief note on theory, both cognitive behavioral and DBT have a lot of support, which of course DBT is an offset of CBT, but they have the most support for acute suicidal ideation. And the rationale behind this is that your brain is just having a hard time when you have suicidal intent or ideation. Your brain has a hard time with proportion, the size of things, but also the length of time and the ability to overcome things. It reminds me a lot, honestly, of the adolescent brain. We know that in adolescence, you literally, because of the brain chemicals, cannot see long term. And so everything that happens feels like it's the last straw. And when someone is in active suicidal ideation, I think our brains are very similar to that. They can't see what the next step could be, or that there could be a next step. And then after you are past the acute phase, you can explore more of the background behind the ideation, the roots of it, especially if it's ongoing. You probably want to do a trauma history if you haven't already done that, which you'll learn how to do in a little bit. But you want to wait until your client is more stable to start digging into core beliefs and history and the roots of the ideation. All right, so as we wrap up, I want to tell you a little bit about your role play assignment, which I know I did in the syllabus video, but I thought it couldn't hurt. So first, if you haven't signed up for a partner, please do so. The directions for that are in your week 1 module. So you want to choose a role play partner, and then with that partner, choose which one of the scenarios you want to use from the document that is linked in the assignment for Canvas. And talk to each other about it. Choose one that you're both comfortable with. And also, I would highly suggest that you and your partner choose different role plays as the counselor so that you don't feel like you're comparing yourself to each other or feeling like you have to do the exact same thing. So that's not a hard and fast rule for this assignment, but it's a suggestion. Next, you want to choose a risk assessment model that was discussed in this lecture. You can use any of them, but I would ask that you don't use the SLAP because you use that already. So I'd like for you to use a more advanced model than the SLAP method. I really suggest, once again, you don't have to do this, but I really suggest that you learn more about the model through your own research. So look up some articles, watch videos, check out YouTube, look what there might be on like Alexander Street Press and the library database, so that you can have as much information as possible about utilizing that model when you do your reporting. Next, I really recommend practicing the model. I had so many people tell me when I taught 550 last term that they regretted not practicing before, that they thought the words would come and then they just didn't, so they struggled with direct language that was needed, and they struggled with honing in on where to go next in the session and in the assessment. So practicing will really help you with that, because the more you practice, the better you get at it. And then finally, record your role play, do your best to get through the entire assessment. And I'd love for you to make a recommendation for treatment at the end, whether that be a safety plan or hospitalization. So that's your role play. This is the KPI assignment for this course. And so I do want you to take it seriously and do your best in it. You do need to score a 3 on the specific KPI in either this course or when it's measured again during your internship. And when you are the client, look at the case study and make sure that you do present with at least moderate to severe ideation and have enough details to allow your partner to complete their assessment. Please be a good partner. All right, that is all for this week. I know it was a lot, but thank you for your time. I know that these are difficult topics. Take care of yourself. And I just added a little social media post that I saw on self-care a while back that I thought was kind of funny because it resonates with me. And it says, sometimes I will do a very simple self-care thing like putting lotion on my hands before bed and be like, that was so easy. I will do this every day, and then forget I even have hands for the next 6 years. I find that very relatable. So thank you all. Let me know if you have any questions, and I will talk to you soon.